Can you guys help me present this case, please? Huh? Lower your voice. Let me present my case. 9 o'clock. Okay.
Sound check. Brian, can you hear me? Thank you very much. We'll be starting shortly.
How long we get at this person today? What?
a meeting today?
Microphone on? Oh, there it is. I just don't see the light. Finance Committee of the Cook County Health and Hospital System. Will the will the Secretary please call the roll?
Director Deere is absent. Director Harrington?
Present.
Director Robinson?
Present.
Director Story is absent, and Chair Ryder.
Here.
Do you have a quorum?
Thank you, Debbie. Next on the first thing on the agenda is public testimony. We have, I assume we have public testimony.
We have a number of speakers. The first speaker is Tina Montanez. And just a reminder, you have 3 minutes. When you've got about 30 seconds left, I'll give you a heads up.
Hello, good morning. My name is Tina Montanez. I'm a registered nurse in the main OR. I work the night shift and I've been at Cook County Stroger Hospital for 20 years. I'm here today to speak about the lack of accountability and responsibility that Cook County management continues to demonstrate to me and my fellow nurses as healthcare professionals, and especially to our patients. Can you hear me?
Yes.
Okay. As nurses, we feel, well, we are overworked, short-staffed, and underpaid. It is not okay that day in and day out, we work extremely hard to provide valuable and necessary quality care to the most vulnerable population. We should not have to beg this committee, our nursing management and human resources about our retroactive pay owed to us. We are Cook County nurses. We love our jobs and the communities that we serve. We are urging this committee to please listen to us. We know our worth, we matter, and we deserve dignity and respect to be compensated fairly in a timely manner for the demanding work that we provide every day. We request that you use your authority and demand Cook County pay us nurses the retroactive pay we deserve, and we've been waiting since October 2023. We present to you today 700 signatures from nurses throughout the Cook County system demanding our back pay now. Justice delayed is justice denied, and we demand justice for our labor. Pay us what we are owed. Show us that you care, so we feel appreciated and supported, so we can continue providing the highest quality care to the residents and families of Cook County. Thank you very much for listening. Thank you.
Thank you. The next speaker is Genevieve Lewis.
In the midst of waiting 5 months for our retro checks, we are beginning to question why this hospital has not paid our staff nurses yet. Will the IRS send our tax returns faster than you begin to pay your nurses? We need our money. The cost of living has soared. Meanwhile, the board chooses to prioritize spending billions of dollars on agency staff. You have made it clear that staff nurses are not important. Staff nurses have held this hospital together through COVID and chaos. We have ensured quality and safety even when inundated with inexperienced orientees, agency nurses, and managers. Second, our union has had a proposal for an extra shift bonus on the table since Juneteenth, specifically on June 20th, 2023. Why has the hospital not begun to bargain this? I am here to demand these two issues get resolved today and get our nurses paid immediately. We refuse to wait any longer. As you expect your paycheck to be in your bank on payday, county nurses deserve to have that same expectation.
Thank you. The next speaker is Francesca Nuora Takpour, and she is speaking virtually.
Good. Can you all hear me? Good.
We can.
Yes.
Thank you. Good morning, everybody. My name is Francesca Nuora Takpour, and I'm a nurse, a case manager with Cook County Department of Public Health, and I've been with Cook County Health for the past 24 years. I came today to appeal to you, Cook County board members, to weigh in and intervene by facilitating the retro payment to the Cook County health nurses. This retro check was collectively agreed and signed off by HR and the union representing all Cook County health nurses in October 2023. Nurses were supposed to get this retro check by November 2023. We are now in February 2024, and no check has been paid to any Cook County nurse. And this violates our collective agreement with Cook County Health. No reason has been given to the union or the nurses for this violation, except hearing from the grapevine that HR payroll does not have enough staff to complete this task. And how does not having enough staff prevent nurses from collecting their promised wages to take care of our families? Currently, nurses' morale are low. A sizable number of nurses are planning to leave. Most, if not all, nurses plan their holiday around this expected money that never came. Right now, nurses are so disappointed due to not receiving our money. This is why we came to the board members to intervene and ask HR payroll to act in good faith as agreed and pay nurses their retro checks so our morale can swing back, and this will lead to high productivity and good patient experience. We are also demanding the Cook County respond to our 2023 extra shift bonus proposal. The parties agreed to address this, and Cook County continues to ignore and delay talks on this critical and necessary discussion. We want to prevent nurses from leaving the bedside. We want to help recruit and retain good nurses, committed and resolute nurses who love and respect our patients and the communities they represent. We urge you to consider these issues and to act on them today. Our livelihood depends on it. Thank you for your time, and we look forward to your consideration and cooperation.
Thank you. The next speaker is Joyce Ball, who has joined us virtually. Joyce, are you there?
Yes, I'm here. Good morning. My name is Joyce Ball, and I want to say good morning to the Finance Committee and everyone that is present. I'm here on behalf of the nurses of Cook County Health System, and as well as the NNOC members. I'm here to request retro pay that is owed to the nurses from 2021 up to 2023, as well as myself and many of our colleagues have donned the workplace with masks, gowns, gloves, and hazmat suits as well, to protect our patients as well as ourselves from this devastating COVID virus that was taking many of the nurses out. We have lost and succumbed, many have succumbed to death in that event. I had a colleague that actually called me during the height of COVID, that called myself and many of the staff just to say goodbye. The person said to me, I might not make it in the morning. And so we were attacked emotionally. That was a very emotional event. And so that my colleague was attacked physically with this devastating event. And many times I drove to my house after leaving work, and I just sat there and cried and I cried and I cried because I didn't know if I would see my colleague the next day. But lo and behold, he was able to succumb and he was able to beat that. But many of our nurses, over hundreds of nurses did not make it. And so now we've been asking for this, and all they gave us was an insult of $5 if you work the specialty area. That was a big insult. So we have waited November as we were promised. We was promised in December. We was promised January that we would get this money. Here it is February. We're halfway through the month, and still nothing. No one is talking to us. No one is telling us why to wait. So I appeal to you that if you can and if you will, please consider what we have gone through. We have gone through hell and high water to be where we are today. And so I'm asking that you will look and as soon as possible, give us what we are owed. Thank you.
Chair Ryder, that concludes the oral testimony. There were 2 written testimonies that were submitted, which will be included in your e-packets that get sent out after the meeting and will be posted on the website.
Okay.
Additionally, I received some petitions from NNOC that they asked to be included in the record and sent to you. So those will be scanned and sent.
Okay. All right. Thank you, Debbie. Thank you to our speakers. We will, thank you for alerting us to the Finance Committee to the issue. We will certainly take it under advisement and, look into the issues that you've raised. Good. All right. Next on the agenda is consideration of the minutes of the Finance Committee meeting for November 9th, 2023. Do we have anybody participating virtually?
No.
Okay. These minutes were approved at the January meeting, but are being presented for the committee's review and discussion if necessary. Are there any corrections that need to be made to the minutes? Any corrections or changes?
No.
All right, hearing none. Is there a motion to accept the minutes?
So moved.
Motion's been made. Is there a second?
Second.
Motion's been made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed? The ayes have it. I will also note that the next regular meeting of our committee is scheduled for Thursday, March 7th, 2024 at 10 a.m. All right. This brings us to items under the Chief Procurement Officer. I'm going to ask our Chief Procurement Officer, Charles Jones, to join us at the table. Charles will be presenting along with the executive sponsors of the various procurement items. I believe, Charles, we have 31, right?
Yeah. Good morning.
So not the most that we've had recently.
I know.
Still up there.
Decent, consistent number. Actually, 30 of them are contract and procurement items that will require a responsive letter from the Office of Contract Compliance. We have 16 back with 14 still in process, and the 31st item is.
Okay. All right. Anything else before we dive into them?
No.
Okay. All right. So the first two are being presented by Dr. Hasbrook. They are for the Cook County Department of Public Health, and Dr. Hasbrook is our Chief Operating Officer. Mar, how are you?
I'm good, Chairman. And good morning to the.
Looks like I got you on the shoe game today, too.
Yeah. So I have two, as has been mentioned, and they're both grant funded. So the first one is a vendor called Catholic Charities. It's an increased contract fiscal impact of $80,000. They are a subgrantee, and this is to continue to provide capacity and expand the staffing for the Homeless Prevention Call Center. Pretty straightforward. The second one also grant funded. It is to increase contract. It is a vendor by the name of Public Health and Safety. Fiscal impact of $65,000. It's a blend of some ARPA funds with some HUD funding for lead inspection assessments, remediation, and repair for folks who are in our jurisdiction who have lead poisoning contamination, namely through lead paint. And that's to continue that work. Any questions?
Any questions for Dr. Hasbrook?
None here.
I have a question, Dr. Hasbrook.
Yes.
And I continue to ask this question, but do you have a guess of how much it costs if a child receives lead poison from eating the sweet tasting paint on their wall? What is the cost to the system? Because I'm under the assumption, and correct me where I go wrong, if that individual is a part of what we are looking to assess, then it's a great chance that they actually are visiting Stroger or some affiliate, one of the clinics.
Yeah, that's a great question. I don't have that number. I can get that for you.
Yes, I
Yeah.
recognize this is.
Yeah, I would say hundreds of thousands of dollars, when you talk about, the impact to the health system, the impact to the life trajectory of a kid that's, seriously lead poisoned because of the brain development, because of the, behavioral, problems and challenges in school. So not only, you can't really take the lead out once it's been contaminated, but in terms of the life course of that child, or many children who are exposed in these lead contaminated homes, I would say hundreds and hundreds of thousands of dollars, in direct and indirect costs to the lives of those kids that are affected. That would be my guess.
That guess is 100,000 to the collective or to the individual?
To the collective, to the system.
Collective.
Yeah.
Now, again, I know you don't have the numbers, but could you just suppose that to the cost of remediation?
Sure. So to remediate a house costs about $40,000 in a period of somewhere between 3 and 6 months or so. Families are displaced; they have to be put up while we have the remediators and the folks come in and then repair the lead of the home. So it's about $40,000 to $50,000 per home.
Okay, thank you.
You're welcome.
Of course, these are all just back of the napkin.
Yes, of course.
Completely wild guess. I just wanted to understand.
Okay.
As I've said before, the problem is just going on too long.
Yeah, I mean, we have lead contaminants in our system. I think we've seen this in a variety of places with lead water pipes and things, paints and things like that. And other contaminants, they also exist in the environment with a community that has such old housing stocks, asbestos and other contaminants that get removed or are no longer used in new construction. So, yeah, for sure.
True enough. Now, I'll take the moment to make the distinction between the asbestos. The asbestos only becomes an issue when it becomes friable. So if it's just there in the house, in all scientific method, it causes no problem. The paint is a little different program because of the active nature of a child.
Well, the paint, and then also, as we saw with Flint, the consumption of water that's, and Flint had a double problem because they had the pipe and then also the recirculation of contaminated water from the water system in through those pipes again. So
True, for sure. Agreed.
all right. Any other questions for Dr. Hasbrook? Hearing none, we're going to move along to requests number 3 through 6, health plan services, which are being presented by our Chief Administrative Officer for Health Plan Services, Aaron Galiner.
Good morning, directors. The first item here before you is a request for a 1-year extension of our text messaging vendor. We do have a current RFP in process, but this will give us time both for transition and to ensure that transition happens after the initial large wave of redetermination completes, which we expect to complete about 6 months from now. The next item is a 3-year contract as a result of an RFP for $57.8 million. This includes both administrative fees and the cost of claims that will be paid directly to non-emergency medical transportation providers. This is replacing one of our current vendors that provides non-emergency medical transportation. The next item is a state-required contract. This is a program that is between the state, CMS, and also includes all of the Medicaid managed care organizations with Lurie Children's clinically integrated network. This is provide enhanced care coordination to the pediatric population in 2 specific zip codes in Cook County.
What zip codes are those? They are 60639 and 60651. And then my final item before you is a sole source request for Athena Health. This is a EMR system that a number of the providers in our network utilize. This would be to be able to extract supplemental data from that EMR and be able to utilize that for our
HEDIS data submissions that we have to submit to the state.
Thank you, Aaron. Our next series of requests are going to be presented by our Chief Medical Officer, Dr. Claudia Fegan. Claudia, good morning.
Good morning, directors.
Good morning.
So the let's see, first item is for the provide orthopedic supplies that we use for implants and a variety of other surgical procedures. The next one is a contract that's medical necessity guidelines required by the managed care organizations to support the delegations of medical necessity review. This is a sole source because the vendor provides specialized services existing in licensed software that has currently been implemented at CCH. And we anticipate having an RFP for this posted in the second quarter of 2024. Okay, the next one is Jubilant is a company that supplies a generator that produces the radioisotope for cardiac PET or PET imaging. And so cardiac PET imaging is used for cardiac stress testing, myocardial viability imaging, and cardiac sarcoid, a condition infecting the heart muscle, and cardiac device infection imaging, so such as prosthetic valves when patients have endocarditis. For cardiac stress testing, this is more efficient than the current modality that we use and results in lower radiation exposure. Using the PET testing, we can do the procedure in 45 minutes as opposed to 3 hours. And coronary flow reserve measurement is very helpful, particularly in women who have coronary microvascular dysfunction, and it has a higher diagnostic accuracy. Okay, yes. So the next one is allows us to take labeled radioisotope and perform measurements of the patient's blood volume and plasma volume. And so these measurements allow us to be more accurate in our treatment of patients with heart failure and results in fewer readmissions for patients who are treated with heart failure. I'll be happy to take any questions.
With these new technologies we're implementing, do you anticipate there'll be better outcomes moving forward?
Oh, absolutely.
So will we be able to see that? I mean, you'll be keeping track of that and you can report to
We're
us?
going to be tracking it, but we expect that our patients with heart failure will make more accurate diagnoses, and oftentimes we struggle with determining what the volume status is of those patients, and sometimes we dry them out too much and result in kidney injury, so we expect to have less of those complications, and those patients are less likely to be readmitted because we haven't adequately removed fluid. So, and the patients with using the PET scan for stress testing will allow us to do more patients, a greater volume of patients over time because it takes less time to do the procedure.
It'd be interesting to see what's happened over the course of a year.
Yeah, we'll have to track it over time.
I do appreciate the investment in our cardiac services, considering that we have these meetings in the morning, and you're more likely to have a cardiac event, you know, upon waking. So that's good. That's good for all of us sitting at the table.
Thank you very much.
Thank you, Claudia. Does anybody have any questions for Claudia? No. All right, great. Thank you. All right, Charles. Where the next set are, actually it's request number 11, equity inclusion, which is going to be presented by Shannon Andrews.
Yes, I will be presenting on behalf of Ms. Andrews. She sends her regrets as she is participating in the Behavioral Health Summit this morning. So I believe she may be in the virtual sanctuary too, in case there's questions.
Okay.
I can't answer. All right, for request 11, we're asking you to execute a contract with In His Hands Resource Center for housing navigation programs and partner services. It's $377,000 over a 24-month period, that's, grant funded through, opera. It is the result of an RFP where we had 3 respondents, to respond. This request is for the provision of community-based organizations to serve as the housing navigation, program partners, integrating with hospitals and health clinics to, manage referrals. It would serve the city of Chicago and will work on site at Stroger and Providence hospitals, provide services to CERMAC and CCH clinics located in the city of Chicago. Vendor will serve approximately 75 persons per year with housing triage, referrals, placements, and housing identifications. Also, we'll partner with the Chicago Continuum of Care for coordinating entry systems, access, and other outreach and navigation service. Contract will have a 2 one-year renewal options. Again, 24 months, $377,000 grant funded.
All right. Any questions for Charles on request number 11? Hearing none.
Thank you.
We've got request number 12.
Perfect.
Curtis.
Thank you. Good morning, Curtis
Good
Bailey,
morning.
Chief Revenue Officer. Today, we'll go through the first one here. It's a request to execute a new contract with Flywire. This is through an RFP process. We had 3 proposals during that process. This contract will replace 3 existing patient payment processing contracts that we have. It'll also replace 2 print mail agreements that we have, and then additionally, it will provide a chat box features for our customer service team to connect with our patients.
All right. Any questions for Curtis? Hearing none. Thank you, Curtis. We'll be hearing from you again later, right?
Correct. And then I have one more on the list here.
Oh, I see it. I'm not sure because I got 13. See, you guys don't have my cheat sheet. I got a couple people on here, so I don't know if it was you, Pam, or Angela. So go ahead, go for it.
Perfect. Thank you. So the last one is a request to extend our 3M agreement. This is for computer-assisted coding for 1 year.
All right. Any questions on request number 13?
No.
Hearing none. Thanks, Curtis.
Thank you.
All right. Request number 14 and 15, Human Resources. Our interim chief HR officer will be presenting these. Carrie, good morning.
Good morning.
Good morning.
Carrie McVoke, Interim Chief Human Resource Officer. The first one up is related to our cross-country contract that was extended last August, September timeframe through April. However, this is for additional monies to cover the October 2023 through the April 2024 extension. And it's for the recruitment. There are our RPO team who works on sourcing and recruiting efforts for all of our positions here at the health system.
All right.
This next contract is with Boxwood Technology, and this is a group that it's for 1 year extension. It's sole source, and they currently post for us our positions, a sourcing resource for us regarding our doctors, our management and leadership roles, as well as our job fairs. So we did we amended the contract during this extension period or not the extension period, during the new contract period to include job fair sourcing efforts as well to increase our traffic at all job fairs. So this is, we've been working with them. We've had really great success, and we'll hopefully continue to get that success from them.
Great. Any questions?
I have a general question. You indicate a number of roles that we need some assistance with in terms of hiring. I think that's nationwide. I mean, are these the positions that are most difficult to fill currently?
They are. They're difficult.
So we're not alone?
No, we are not alone, no. We're competing with a lot of different organizations and industry.
Any other questions for Carrie? These contracts will help us hire people. I like it. Thanks, Carrie. All right. Request number 16 through 26. Craig, you're going to take us through these efficiently and
I will.
quickly, right?
I'll do my best.
All right, our
First
Chief
one-
Administrative Officer, Rick Williams.
Thank you. Good morning. The first one is for Imperial Parking. It's an extended increased contract for $2 million, 6-month contract period, 4/1/24 through 9/30/24. And they provide our parking management services at all of our garage as well as our service lots. Includes cashiering, janitorial, and security services. We're posting an RFP for this in 2024. ABM Healthcare, this is for our shuttle services that provide loops from JTDC Garage, Stroger, and Admin Building. It's an extended increased contract for $1.2 million, and it's a 12-month contract period, 5/1/24 through 4/30/25. McDonough Demolition, it's extended increased contract for $496,789. 12-month contract period, 2/1/24 through 1/31/25. And this is related to the demolition of the Senstack building that happened a couple of years ago. What was left was sort of an unpleasing presentation on landscaping and fencing, and so we're having them come back and address that.
Make the property more welcoming.
Exactly. It's like a chain link fence with a curtain on it, so we're going to put a nice steel fence outside. Alta4 Industries, an extended increased contract for $225,000, a 12-month contract period, 4/1/24 through 3/31/25. And they provide preventative maintenance, repairs on our 8 emergency generators at Stroger Core and the Professional Building. This is a sole source because we're the only authorized vendor to perform maintenance on our particular equipment. HOH Water Technology is extended increased contract for $200,000. This 12-month contract period, 10/1/23 through 9/30/24. And they provide chemical water treatment services at Stroger and Provident on our RO systems. And our RFP will be posted in 2024. Interstate Electronics Company is an extended increased contract for $100K, 12-month contract period, 5/1/24 through 4/30/25. And they provide maintenance and repair on our nurse call and overhead paging system here at Stroger. Vertiv Corporation is extended increased contract for $75,000, 12-month contract period, 4/1/24 through 3/31/25. And they provide maintenance and repairs on our uninterruptible power supplies for our data center. GE Medical Systems is for ultrasound and primary care diagnostics. It's execute contract for $552,000, one-time capital purchase, and this is to provide point-of-care ultrasounds across our inpatient service. There's about 50 total systems that are coming in as a result of this. GE Medical Systems is an execute contract for $314,513, again, a capital purchase. And this is for 84 Dynamap vital sign monitors, which we use across our ambulatory care network. Devacor Medical Products is an execute contract for $289,300, 36-month period, 3/1/24 through 2/28/27. And this is for a 3-year service agreement for our Mammotone biopsy system. Henriksen is an execute contract for $159,870. The 12-month contract period, 3/1/24 through 2/28/25. And this is to provide waiting room, exam room, and conference room furniture over at the Core Center. And the last is Chicago Lighthouse, which is an extended increased contract for $1.74 million. It's a 12-month contract, 3/1/24 to 2/28/25, and they provide overflow calls for scheduling, registration, insurance verification across our ambulatory network as well as county care. And we're exercising the second renewal option on this contract. Happy to answer any questions on any of those.
Any questions for Craig? Hearing none, thanks, Craig.
Thanks so much.
Request number 28 through 30. Donica, good morning.
Thank you.
Our
Good morning.
Chief Hospital Executive here at Stroger.
Good morning. Thank you, Chair Ryder. Good morning.
Good morning.
Directors. Before you, I have an execute contract for Nova Biomedical. They provide glucose strips, Nova glucose hospital meters, single docking stations. The contract amount is $775,000. The contract period 4/1 of 2024 through 3/31 of 2029. These glucose strips, the docking stations, will be both for Stroger as well as Providence. The next one before you is an execute contract for GE Medical in the amount of $419,268, one-time capital purchase. This is a request for the provision of telemetry and monitoring equipment. This is for the new 4,800 cardiac expansion to increase our patient census for monitoring and telemetry capabilities for physicians as well as the clinical team. And the last one is an execute contract with the University of Illinois for neuropathology attending teaching services in the amount of $196,176 for the contract period 3/1 of 2024 through 2/28/2025. This vendor will provide an attending neuropathology for Stroger Hospital. Also, residents and other educational functions will be covered under this program. Currently, the Department of Pathology does not have the personnel, so this is a request for a sole source with the University of Illinois at Chicago, because they're the hospital that is in close proximity that can provide in-house neuropathology pathologists, as well as final diagnosis of our brain specimens here at Stroger.
You indicated this was currently, does that mean that we're looking for someone to provide this service for us?
Exactly.
So that's on that list?
Yes.
A long list of people we need.
Yes.
Thank you.
Thank you.
Any other questions for Donica? Hearing none, thank you so much. We're gonna go to request number 31. I assume our general counsel is on the phone. Jeff, you there?
Yes, good morning, Chair Ryder, thank you. I sent a detailed memo about this request earlier in the week, but in general, the issue here is that this particular vendor, who is a county registered WBE, has two separate contracts with two different using departments at CCH. And a lot of the work that was done for the other using department wound up being charged to the Office of General Counsel contract, which ran us out of money. So this money is necessary to pay for legal services that were provided to the Office of General Counsel.
Any questions for Jeff on this item? Hearing none, thank you, Jeff. All right, getting back to Charles. Charles, is there anything else you'd like to add before we take a motion on these requests?
No, sir, that's it for the contracts and procurement items.
Okay, so I would entertain a motion to approve item 4A, contract procurement items containing requests number 1 through 31, subject to completion or review by contract compliance.
So moved.
Motion's been made. Is there a second? Second. Motion's been made and properly seconded. Any discussion on the motion? Hearing none. All those in favor signify by saying aye.
Aye.
Opposed? The ayes have it. Moving right along, Charles, would you be able to present the MBE WBE report for this month?
Yes, sir. And actually, it's rounding out the last quarter since we had our finance meeting, so it's a couple months. If you'd bear with me here, September, October, November, and the total year to date for FY23.
Great.
So looking all the way on the left, there was 21 contracts presented during the month of September. Of those 21, 12 had contract-specific goals, a little bit over 62 million, about $63 million if you round it up. We had two primes participation of 12.2 million and 10 subprimes for 5.4 million. So about 6 participations total for a little bit over 17 million, $17.67 million there, and about 28%. The month of October, out of the 24 contracts presented here, 11 of them had contract-specific goals. Two of those again were primes, 2.8 million, and 4 subprimes for 13.1 million. So six contracts of participation in that particular month as well for 15.9 million, and somewhere in the neighborhood of 29% participation. Then finally rounding out the quarter, last month of fiscal year for November, 34 contracts. Of those, 16 had contract-specific goals for 45 million. 7 of those were prime, $31.4 million there. 6 subprime, $12.042 million. So 13 contracts, 13 of the 16 had participation for $43.5 million. We did have 3 waivers during the month of November for 2.9 million. Yeah, so looking at the total year now, your 4 column all the way to the right, 103 contracts and 674 million had contract specific goals. We did 26 prime MWB vendors were prime vendors on 26 of those for 72.2 million, and 56 of the vendors were subprime for, subcontractors for 139 million. So 82 contracts during the year, total 211.9 million, so roughly 212 million, somewhere in the range 32% total participation for the year on contracts that was presented to the board. So Sam, if you want to.
Can
Yes.
we add a metric, because that total for the year, the 32% doesn't get drawn out specifically. So when you look at this, you see the what's our goal?
It's for goods and services. It's 25% minority, 10% women-owned business. Construction, 24% minority, 10% women, and professional services is 35% either or.
So our overall numbers are good. I just think that maybe having something that gives us what the overall is versus components would also be helpful, because I think you would agree we're outperforming the goals, correct?
We're looking pretty good.
We're at or above the goals. Definitely. You can tell me if I'm wrong.
Yeah. Well, I have a visual on the next chart.
Okay.
For a bar graph.
Let's do it.
Yeah.
I think when we have those numbers there, it's good to add another line that draws it in.
Mm-hmm.
All right, go ahead.
So yeah, so there you
Talk me through this.
Yeah, so there you see that 28% September, 29% in October. November is 96%. That is definitely abnormally, but we'd love to have that on a regular basis. So there, the total year overall, 31%. So right there in the ballpark of what's the aspirational goals are.
Okay.
And again, we work hand in hand with the Office of Contract Compliance for the county, office under the president. They do a very good job of collaboration and working with us, working with the vendors.
Yes.
Yeah, picking up on that, it would be interesting to look at how this compares to the prior year. You could add another bar and we could see year to year.
Yes, that information is available once a year during probably late summer, early fall. The Office of Contract Compliance does, because they are the official author of this, they do a report to the Board of Commissioners as well as us for it. So, and we track the trend.
Thank you.
You are.
All right.
That's it for that one.
Anything else on the MBE report, Charles?
No, sir.
All right, any other questions on it? Hearing none. Next, we'll move to the fourth quarter fiscal year 2023 report of contracts executed under the authority of the CEO, which are contracts under $150,000.
Yes, sir. So for the final quarter here, September, October, November, there were 17 contracts executed for under $150,000 under the authority of the Chief Executive Officer. Of those, a little summary there, of those 17, 5 of those were GPO vendors, 5 were grant funded with grants, and 8 were capital equipment purchase. All 17 were responsive from the Office of Contract Compliance. Looking at a couple of the higher dollar ones, the CDW government here as a GPO vendor. We bought capital equipment for HIS or business intelligence, $146,205. ECLA Corp, capital equipment, we bought EKG and carts and defibrillators for the health system for $100,000 there. Elrod Freeman LLP legal services, $149,000. And then scroll on, and then second from the last task, which is treatment alternate for safe communities, a grant purchase there for $107,360. That was OD2A, Overdose Data to Action Grant. That had a Community and Law Enforcement Deflection Leadership Summit. Any questions on this report?
Any questions?
You know the total? We have a long list.
Yeah, I can, I don't have it here now, but I can run a subtotal and give it back to the board secretary to give to you. Okay.
Report of emergency purchases.
Sir, so that was 7 total since the last time we met as a finance committee. Alivio Medical was done in the month of November. November 20th, presented to the chair of the board and chair of finance to extend and increase that contract that we had with Alivio Medical Center. The vendor continued to provide bilingual patient community facilitators for the obstetrics departments of our ACHN clinics, $317,000 there with a 12-month extension.
You know what the, and you don't have to answer that, what the volume of patients we have that need the services.
I can talk to the department and get that for you. Okay, next one, capital equipment purchase with GE Precision Healthcare during the month of December, one-time capital purchase there. Vendor provided ultrasounds and ultrasound probes for operation and development for various departments throughout the health system, $4.2 million. We extended and increased the contract with Favorite Healthcare for a 4-month period so that the vendor continue to provide various agency staffing to assist with our new arrivals for the ambulatory community health clinics in the amount of $682,000 increase. In January, we did a contract with Stuart Spencer for 12 months, this vendor to provide professional consultant services for our executive search on behalf of Human Resource Department, $400,000. Also in January, Global Imaging Specialist, 12-month contract there for teleradiology services, $1.3 million on behalf of the Department of Radiology. Also in January, Mount Sinai Community Foundation doing business as Sinai Medical Group, 12 months there for the Department of Radiology for the provisions of clinical physician services and coverages, $1.2 million. And lastly, a new contract with Sellers Dorsey and Associates for 12 months to provide project management services for county care health plan services and the managed care organization in the RFP preparation, $689,000 there. Any questions on emergency purchase for the last several months?
Any questions? Thank you, Charles.
All right, that ends my report. Thank you.
Thank you. Moving on, we next have a report from our Chief Financial Officer, Pam Cassara, who will be presenting grant award related items.
Good morning, Chair Ryder. Good morning. Before you today, we have the receive and file for grant reward, related items, a small amount this month, 764,000 basically. Debbie, if you could kind of scroll up and to the summary there and make it a little bigger. Just summarizing how many are amendments, carryovers, extensions, and renewals. The only thing I want to point out there is that the amendment, showing negative is correct. It was actually a reduction in an award, from the Illinois Breast and Cervical Cancer. And Dr. Hasbrook may be able to speak to that if there are any questions. I know several of the sponsors are out for the behavioral health. Any questions? Hearing none, also in your materials, before I turn it over to our special guest, are the December financials, the 1 month ended December. We're not going to review those today, but they are in your materials. We have a special presentation on revenue cycle update.
Perfect. Thanks, Pam. Good morning again. Curtis Haley, Chief Revenue Officer. So today's finance update will be an update on the revenue cycle turnaround plan that we kicked off back in late 2021. We'll go through the status of that, talk about our accomplishments in fiscal year 23, our initiatives that we have going in fiscal year 24, some denial work that we're doing, and then review our costs for some of our purchase service expenses and the returns on those. So what you see here is a snapshot of our timeline for our turnaround plan. Where we started was the blue stars there. So overall, the revenue cycle maturity was basic at that time back in late 2021. Since then, we have progressed quite nicely to where the green stars are in each one of those swim lanes. And collectively, we are slightly ahead of target of where we expect to be at this time in the turnaround plan. Each one of these swim lanes represents some of our categories of initiatives that we're working on, the whole process, people, technology, scenarios. We have created standardized operating procedures to improve our processes, consolidated our policies, recently implemented technology. We had some success in recruiting revenue cycle leaders and other positions over the last couple of years, and connected with our BI team to expand our visibility toward our performance management metrics, both internally and externally. So with that being said, we'll move to the next slide. Thank you. And so what you see here are our accomplishments for fiscal year 23, starting with the fiscal resilience pillar. AR over 90, we were able to drive that metric down, starting at 35% down to 29%. We were able to liquidate some of our aged AR there, bring some cash in the door, which helped us drive our cash collections metric. As you can see there, in fiscal year 22, we brought in $584 million, and in fiscal year 23, we brought in $829. So some significant improvement in cash collections. Another big focus this prior year was transitioning our professional coding, collections, and billing and prior authorization work from a vendor called RISARC to bring it in-house in a combination with the partnership on a new vendor. With that transition, we were able to improve our coding accuracy from 85% to 98%, which is a great jump, and then decrease our late charge metric from 16 to 6. We also focused on the growth and innovation and transformation pillar by some recruitment efforts, and we're able to bring on a director of patient financial services, a director of revenue integrity, senior manager of financial assistance, and a regional senior manager of revenue cycle, which those three regional managers are going to be key to our fiscal year 24 initiatives, which is to improve revenue cycle performance out at the clinics now. Additionally, in 2023, we were able to expand our CDI virtual training platform to include our residents, our attendings. Historically, it was designed just for our residents. So now we have our attendings rolled into there, and we expanded the curriculums in that training platform. We also created a revenue cycle virtual training platform from the new support teams that we've created and have grown, and then created standard operating procedures, detailed standard operating procedures for the back end. With that, we'll move to the next slide in fiscal year 24 initiatives. Some of them are the same that we focus on in fiscal year 23, that being AR over 90. We ended last year at 29%. We intend to drive that down to 25% by the end of the year, which should drive some additional cash collections as well. Last year was our best cash collections for a system in over 10 years at $829 million, but we do anticipate to surpass that at over $900 million this coming year. A large focus this year is on front-end revenue cycle, which includes pre-access and patient access. The metrics that we're going to focus on are POS cash collections. This past year, we ended at 11.2. We will drive that over 20% this year to best practice and have to create those detailed standard operating procedures to guide the teams. We also have a few initiatives under the growth and innovation pillar. With recruitment, we are creating a revenue cycle systems team to help us manage all of the revenue cycle systems that we have deployed to ensure that they're operating the way that they're intended and on schedule. We're also redesigning our financial assistance team to ensure that they're deployed and accessible to our clinical teams and patients where they need them the most. Additionally, we are connecting with and aligning with the ACHN operational leaders and the new revenue cycle leaders to improve the front end performance metrics out at the clinics.
How many revenue cycle systems do we have, since you said systems?
We have at least, without having it in front of me, a dozen, give or take a couple off that number, so that we can move on to the next slide and chat through our denial reduction efforts. What you see here are our top 3 denial reasons that we've been focusing on: untimely filing, prior authorization, and patient access. The first one, untimely filing, this last year we expanded our billing and collections teams and optimized their work queues. By doing so, we were able to drive down this denial reason by 11 million from roughly 26 million down to about 15. We're going to continue improving this coming year by implementing a real-time claim statusing and eligibility tool. We're going to integrate with a healthcare-specific work comp and liability partner and transition that work away from the state's attorney, which they have approved, and then integrate with an international AR partner to start liquidating some of the international AR with the payers over there. The next one is prior authorization. This scope was primarily RISARC historically, and we transitioned away from RISARC. In order to do that, we had to expand our internal team and update their job descriptions to reflect the work that had to be done. We saw a slight improvement there with that work by improving this denial by 300,000. But the majority of this improvement will come in this fiscal year as we work with the unions to create the MOAs needed to set those production and quality standards. And then obviously creating those standard operating procedures while we work through this improvement. And then finally, for denials is the patient access category. This prior year, a big step in success was recruiting those regional managers for the ACHN sites. With them being on board, we began the work to work with those ACHN operational leaders on optimizing the front-end registrations, getting visibility to how they're performing. And we've seen a slight reduction in this denial by 700,000, but the real reduction will come this fiscal year as we create all those standard operating procedures and standardize the work that they're doing, and then align with our revenue cycle OKRs with the ACHN operational leaders. We're all on the same page moving forward.
This is impressive. Thank you. If you achieve the goal, it's very impressive.
Thank you.
I have a question.
Sure.
On your untimely filing, they integrate with the international AR partner. If you can guess, if you don't know, what would be the amount of revenue that we receive as a result of international?
That is unknown at the current instance, because when international patients come over, they give a local address of where they're staying, so we don't know to the degree of which patients are international until our partners have databases to run their demographic data against to identify if they are international or not. And yeah, and the contract is contingency based on their collections.
So when they walk in the door, we don't know.
Correct.
Okay, I don't know the procedure, but is it customary to ask, provide some type of identification?
Absolutely. Yep.
And so they have something that is American-based?
So when these patients come in, we ask for their address, and typically they give the address of where they're staying, not their address overseas.
But you don't ask for any type of identification to prove that address is valid?
Not on the address verification, no.
This gets into being able to accept people that are immigrants or people that are undocumented. So at a certain point, you ask for identification. If nothing's presented, you take what you have. And correct me if I'm wrong on this. So at some point, there a gap can develop. We have, regardless of the current migrant crisis, we have undocumented people in our area that come from all parts of the world: Europe, Asia, Central and South America. So and this is again an important resource because we're probably more likely to see those patients than any other health institution in our region.
Yeah, I can offer a personal example. I had a friend years ago. She was Consul General of the South African Consulate and lived in the northwest suburbs and wound up at Stroger getting medical care. So not all of the people might be working here.
Yep. It would come up in a lot of different contexts, especially with an international city like Chicago.
The question is based off of, I was under the assumption, and clearly it sounds like it's wrong, that we had people who literally fly here because the care is so good, and then they will fly back out but not pay their bills. So it sounds like that is a wrong assumption.
Director, I think there is some of that, especially, for example, deliveries. And they come over and they deliver their babies and they go back home. But again, we don't push, as a chair writer said, for necessarily for identification. And when they're showing up emergently, we're not denying care, or we're not making arrangements before the care, right, to ensure payment up front or, something like that. So the international partner will help us to, find these patients and collect. And a lot of them do, mean to pay their bills or do pay their bills. They're not trying to stiff us, but, initially when the care is given, we might not know that information.
Yeah, regardless of what their standing is when they come to a place, they're coming to Stroger, or Providence, they're looking to get treatment, and the accounts receivable portion that we've got to work with is not front of mind for them, because they're usually dealing with a calamity. Because the last thing, unless it's a planned, like people on labor and delivery, they're not looking, like any of us, they're not looking to go get health care abroad. It's for a variety of different reasons.
Another benefit of partnering with an international AR partner is some of these patients have insurance back home in their home country that we don't have the ability to bill.
Or travel insurance.
Or travel insurance, correct. And this partner can do that for us. They have offices throughout the globe.
Yeah.
Assisting that.
And healthcare varies so much internationally, whether it's nationalized or whether they have some other different form of healthcare.
Absolutely. Any other questions? Great. We can move on to the next slide. All right. So this slide represents our purchase services, are the top three vendors that we have in terms of expense. First one on the list there is Guidehouse. Guidehouse scope is to assist revenue cycle with temporaries support as we have the different projects in our turnaround plan. As you see there, this last fiscal year, they were able to help generate just shy of 163 million through these different projects, with a cost associated at 12.5 million. The next partner is Salud on the list. Salud Scope is a zero balance account vendor. That is essentially where they get all of the accounts that we bring to a zero balance, and they review it for lost liquidity or missed liquidity for the insurance payers only, not self-pay. And they'll pursue those accounts if we missed any reimbursements. They'll bill it and collect it, and then we get the money in the bank here, and then they have a contingency rate based on that. So this last year, they were able to drive and find 38.7 million, which incurred a $6.8 million expense. And then the last one on the list here is Meduit. Meduit is an early out vendor, which is essentially an extension of our customer service team. They do outreach call campaigns to our patients that are receiving statements and educate them on the financial assistance programs that we have available to them to assist them in their bills. If they don't qualify for any of those financial assistance programs, then they work with them on flexible payment plan arrangements. Those payment plan arrangements have increased in the last year, which has driven the $2.3 million in collections from them. They are contingency based as well, which created that $225,000 expense. Moving on to the last slide, which is probably my favorite slide, shows fiscal year over fiscal year cash collections as a system, all the way back to fiscal year 2011. And collectively, the system has averaged about 300 to 325 million every year. Since we have kicked off this revenue cycle turnaround plan back at the end of fiscal year 21, we have doubled and or tripled the average yearly collection, which is fantastic performance by everyone in the system and the collaboration there. I will call out as my last statement here that we do intend to even surpass the system record of 829,000 collected or million last year to just over 900 million in fiscal year 24. With that, I'll conclude the presentation and open up for any questions.
Any questions for Curtis?
Good job.
Thank you.
Comment. All right, thank you, Curtis.
Thank you.
If we didn't note this already, I think Pam already did the December 2023 financials. We're not planning to review them today, but they are included for the record, so you should have them in your packets. Next up is a quarterly report on the VIA contract, which is going to be presented by Dr. Bina Peters, our Chief Nursing Executive, and the returning to the chair, Charles Jones, our Chief Procurement Officer, for his second time at the plate today.
And Chair Ryder, I don't believe that we did the receiving and filing of the grant award items. Maybe I didn't put the motion in there.
The motion to, I don't believe so. I think we just moved right on into Curtis. Is there a motion to receive and file item 5A, the grant award related items?
So moved.
Is there a second? Second. Motion's been made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed? The ayes have it. All right. Bina, Charles, welcome.
Good morning, all. Here we are going to provide our quarterly VIA update, which is VIA support our nursing agency contract. So we also have a new contract. We'll share the details later, as well as some of the nursing recruiting challenges and also county recognized MDE, WBE usage. Next slide, please. So again, this is the contract previously known as the CNN transition to VIA. And this particular contract supports nursing staff across the system. And the nursing staff includes all the RN positions, as well as the positions that support nursing, which include patient care technicians, the techs, and MAs, and the list of staff. And this particular contract is used for two purposes. One, to really, cover the vacancies. We are aggressively recruiting, but still we are using the number of agency staff to fill the vacancy. As well as we are also using this contract to flex up. Like an example, when we have to open up different clinics, as well as the volume is high, we use them to staff up to provide safe, quality care. Next slide, please. So this particular contract brought in a number of benefits to Cook County Health System, and one is the availability of the pool. We used to have 6 agency contracts, now we have 60. That yielded for us to have a 98% fill rate to support all the activities across the system. And also this particular contract helped us to streamline the billing process. Now we have 5 bills versus it used to be a complex process. And also, recently we have seen the surge in the new arrivals as well as the increase to volumes. So then they are flexible enough for us to support those needs and within 3 to 4 weeks. And as I said, their staffing pool is growing, every month. I feel like they used to have 45 and now they have close to 60 agencies underneath them to support the staffing need of our Cook County Health System. Next slide, please.
What's the difference in cost between the 6 to the 60?
That is, the 60 is the number of agencies.
But I know the dollar cost. I mean, we had 6, but now we're at 60. Is there a significant increase in the cost of these services?
No, the hourly rate is the same across all the agencies. I hope that's, doesn't matter, the rate is a constant rate, how we pay. And also the dollar amount we spend is dependent upon the number of agency staff we are using. And so those are the 2 factors. I hope I answered your question.
I think so. As long as we're not spending more money, we're spending the same amount of money.
Yes, I'll share that slide. There are a few slides about how much we are spending and where we are going. Next slide, please. So again, our goal is to really hire our own staff there. So there are a number of actions in motion. So we are, actively working, to recruit our own agency, which I know our finance section, Kerry can provide more updates. So like, transitioning agency nurses to the staff. And we have expedited hiring process. So, so many activities to really decrease the agency cost and also hire our own. The pilot program, that was probably the most successful program, which I don't want to steal the thunder from the HR update, but we hired more nurses through that new process compared to others. We also had the Nursing School Summit. We partnered with more than 18 nursing schools across the Midwestern area. And we increased the nursing students placement over 125%. In an average quarter, we used to have 137. Now we are close to 300. And also we implemented a nursing externship program. It is the nursing students. We are hiring them on their final, semester with the consideration of them transitioning to our staffing. So really attract them to our system. And that's one of the best practice outside of Cook County too. So we also have a nursing recruitment and retention committee to really understand some of the barriers from our existing nurses and the new nurses and creating number of action plans. Next slide, please.
I'm sorry, question there. You mentioned the word pilot.
Mm-hmm.
Given that we have had such a success, seems like across the board, have we moved to put that as a permanent part of operations?
Yes, in fact, the pilots ended last week, and we are expanding that for 6 more months because we had to make a few more changes. So, and then we will make that as part of our system consideration. I don't want to speak for our HR, leader, but we are extending, and with the hope that we can really expedite the hiring.
Okay, so if there is a need to not continue it, I would like to know that beforehand because I would need justification for not continuing that.
We'll come to you, definitely.
Thank you. Because the success is, the numbers tell the story.
Yep, that's true. Next slide, please. The one before, yeah. So this is the story, actually. If you really look at it, we always look at our net gain, the number of, hires versus number of separations. And actually, this is FY23, we had a net gain of 32 RNs, excluding other positions. So we are actually I believe since 2019, this is the year we are seeing some net gain. So again, back to the new process we put in place is working. Next slide, please. So we touched about the retention rate turnover. So the nursing, we continue to monitor the nursing turnover, which is actually, going in the right direction. Nationally is still about 22%. And we are, now 10 point, around 10, which again from year over year, we are, our turnover is, declining, which is a good thing. Our nurses are staying with us. And plus our turnover includes our retirements. There are many nurses, are, retiring, and they are projected to, number of them also are projected to retire. But still this number is, including them, is much better rate compared to the national benchmark. Next slide, please. So we talked about, again, some of the shortage issues. Nationally projected to have over, 5% of the nurses will leave the bedside according to the latest survey. So that is huge impact for us by 2027. And also the retirement, nationally the nursing retirement age is close to 52. And I mean, our Cook County retirement rate also similar. If the projection is correct, we will expect to see around 25 to 27% of our nurses will be eligible to retire in the next 2 to 3 years. So we are similar to the national benchmark. And also many nurses left COVID, bedside due to COVID, and that is continuing. So those challenges are very specific. We also have significant nursing leadership vacancies, especially the frontline vacancy that is, really help us to challenge to manage some of the complex situations. And also attract the qualified candidates timely. I know we are doing number of activities to, improve the hiring process. Still our hiring time is much longer than compared to the national or local best practices. And also, the part-time position is still on the discussion. Many nurses are looking for flexibility, and that is something we are working with HR and BHR to create that type of position. So to allow the flexibility, we don't have that yet. And the compensation package of the nursing leadership continue to be changing in the market much faster rate than, we can. So those are the, challenges and opportunities. Next slide, please.
What's the question for you? What percent?
Oh, I'm sorry. I was gonna ask, and maybe we've already gone over this. What's our length to hire right now? How many days? I'm looking at Carrie and.
I think it's yeah.
Specifically for RNs.
Oh, specifically for RNs, I can bring that to the next meeting. I have that data upstairs, but if I remember correctly, the overall, we were at 97 at year end last year, and nurses, because of the accelerated hiring process, we were at 71 days.
Okay, so we're improving.
Yes.
Okay, perfect. I remember for the longest time, we were stuck between 90 and 100 days for nurses specifically. Sorry, Bina.
No, that's okay.
Sam, you had a question?
Robert.
Yes. The length, the flexibility part-time, that's anticipated to slow down retirement age or people leaving? What's the anticipated impact?
Attract more nurses to join us as part-time. So then that also gives us the flexibility because other places offer the part-time positions. And plus some of our nurses are leaving for part-time positions. So that is the advantage of having part-time positions.
What's the hindrance?
It's still we are working out the logistic, and again I would like to invite my my partner, Ms. Carey, today.
Officer. So with the part-time, it's what she's referring to as part-time benefited as opposed to part-time non-benefited. We do have part-time non-benefited positions in the organization for those who work less than 20 hours a week. And we have registry positions. But what she's referring to are, the health system and county negotiated years ago part-time positions with NNOC when we didn't have them. And so we have some constraints within the collective bargaining agreement we're trying to work through with all of the different county agencies that are impacted with getting benefited part-time employees into the
organization.
So that request is just not singularly here, it goes across the entire complex of what's called county care, or county, excuse me.
Well, I don't think the implication for nurses specifically impacts the whole county, but how we get it done impacts other agencies and their ability to help us implement, yes.
So if we have part-time here with benefits, then everyone has to have that.
Not necessarily, not necessarily, but it's how our systems have been set up and what we've got to work with when it comes to how things were negotiated in the collective bargaining agreements with what our systems and our processes countywide are set up to do. So we're working through those.
I mean, and this sort of goes to one of the discussions we had in public comment. When you look at the whole of our labor relations and human resources system, there's things that are within the sole, nothing's within the sole purview of Cook County Health. We've got things that are mostly in our purview. Labor relations, payroll, things like that are county-wide operations. So whenever there's a specific issue here, it's also looked at by the county as a potential implication for what they do across the board. In addition, and this might be something that Carrie was alluded to, there are Cook County Health positions that are embedded within other operations of the county, vis-a-vis like the jail, where we also interact with another agency. I don't know if you were going there with that, but that also offers our employees at Cook County Health are also working alongside employees that are directed by Sheriff Dart, for example. So, you know, we don't run every broad labor relations process or benefit process through Cook County Health. All the checks say the County of Cook.
Mm-hmm. The reason why I asked the question is because it sounds as though you're fighting a battle, and the battle being trying to hire these particular people when there are other organizations that can say, I want that same person and I'm going to give you more money, more benefits, and now you have to ask the question, well, why do I go to county? The question has to be asked. What is so good about county that I am going to go to county versus go to these other places that are going to pay me more money, give me more benefits? That's the question that's on the table.
Well, so I don't believe that. I mean, there's a lane where you may be able to get some more benefits, like if you compared part-time unbenefited here versus a part-time benefit somewhere else. But once you get benefits at county, our benefits actually start shooting past everyone else and actually effectively increases. This is like the conversation you and I were having just generally before, is that because of the way our benefits are structured and the employee or the employer sponsor, the employer healthcare, where the healthcare is not, the healthcare is provided in a much more, less on the employee, more on the employer, that effectively increases your salary. So, and the fact that our retirement, that we have a pension system versus a retirement at other systems where it'll be a 401k match type of benefit system, you know, we also look better. I'm not saying that every hospital has that, but predominantly, you know, the hospitals that offer aggressive retirement benefits are other systems that would have collective bargaining, but mostly public systems. So, you know, there is no apples to apples comparison between us and, say, another safety net hospital, or even us versus like Northwestern, because there's other pay and benefit advantages that, you know, oh, I can go this place and make more money. Yeah, can you really once you line everything up? Probably not. So.
Well, then that begs the question. When in the recruiting process, is there a side-by-side analysis broken down to a couple of data points? and being able to spell that out to prove the point. If it is desirable to hire the folks that we are going against, then we definitely have to present the picture as it truly exists, not give the facade. Facade is, I'm gonna give you, say, $100,000 come over here, and they're gonna give you only 80 over here, and so $100,000, who wouldn't take that? But that's not the true picture.
So we do, when we are doing recruitment efforts, and we do provide a benefits analysis about how the county benefits all cumulatively add to their base pay rate. However, getting exact numbers from other organizations is always a challenge because they don't have to share all their data like we do. So we can't really do comparison like us versus Northwestern versus UI Health, but we do tell them about the national averages as well as what all our full benefits packages. And we do have our team is constantly having those discussions with candidates that we are making those offers to, even going as far as connecting them with the pension board before they're accepting offers so that they can really understand our pension structure as well.
So you actually, in that conversation, will say, look, our health care benefits are this. Check your other options and see do they really cover everything we do, because that, as Bob mentioned, that is going to impact the amount of money that you literally put in your pocket.
Correct. That's also why we have a lower turnover rate than everybody else.
Absolutely.
Once someone comes in here and recognizes their pay and benefit structure, they're less likely to leave.
And we get a lot of
But the
them.
Herbie is to get them in, not to keep them. That's the Herbie. That's the blocking point to be able to really accomplish that, and that's what we're tasked with.
I don't think it's just about money. It's about quality of life as well. And some people come here because they once they're here, they know that this is a good place to be. They can do the work that they chose to do, and that in the long term that they will do better than somebody to go somewhere else. So there is something about this, about what we do and how we do it, that attracts people and attracts a certain type of person. But there's an immediate gratification just by, and that's something you can't overcome. If people are looking for money, they're going to go for the money. If people are looking for a good quality of life, they're more likely to stop here and stay here.
I don't argue your point, but I firmly believe that if we can communicate the pluses, that will actually weigh itself out, because a rational thinking person, once it's laid out in a way that they can understand, then they can make a good decision versus a rash decision. A rash is just looking at the raw salary. That's very rash. And that's encouragement.
I think that's what we're saying. We go through that in the recruitment process. What the exercise you're looking for. Yeah.
Okay. Thank you. A few more slides. Next slide, please.
Sorry, Bean.
No, that's okay. Good conversation. So I think these slides go back to our labor spend. I know a year ago, I was in this seat. Our goal was to decrease the agency spend by 20%. And so we are close to 40%. So I don't know, I can celebrate the whole 40% for multiple reasons. One, we actively look at the market rate on a bi-weekly rate and adjust it. It used to be up to $205 an hour for agency. Now it's really coming down to close to $100. So that adjustment is done and is reflected in our total spend. And also, we look at it, there is a gap in recruitment too because of the weather, I think. That November, December, number of agency nurses, nursing agency turnover like almost 100%. People left. So we are recruiting, so there is a little bit gap of close to 40 to 70 FTEs. So that also is reflected in these numbers. But to be in a real number, it's around 20%, reduction. And we are hiring, and also we have productivity system to really match the agency utilization or the workforce management based on the volume. So a lot of activities, but the dollar amount is going down, which is a great news.
Let me make sure I understand you right. You're saying this is total cost, total spend?
For agency per month, yes.
Okay, I don't want to get ahead, but this is fantastic.
Yes.
I mean, it's short of nothing but fantastic.
Yep, this is a bi-weekly work from the whole team every year, looking at the rate and adjusting it, yes. Thank you.
You have to applaud this, because if you're looking at the numbers and you're trying to manage this, you're doing a very good job.
Thank you, the team.
Yeah, the team. And I'm sorry, we asked 1,000 questions, but we should applaud when something like this comes before us because this is great.
Thank you. And we'll go to one more slide to talk about this is the dollar and these are the FTEs. So again, you see the FTEs are coming down. We are hiring. We also that 20%. Due to the market salary rate, the number of nurses jumping into the agency pool is declined. So we do have some gaps around recruiting nurses, but we are working on different logistic. And part of this new contract, we actually put a language for the agencies to give us at least 4 weeks notice so we can, recruit replace those agencies so we can continue to provide safe quality care. So going in the right direction. Next slide, please.
Wait. There's something here that you didn't mention. You have two things, contract labor spend and you have the FTE. So your FTE did not go down by as much as your cost did.
Because of the rate adjustment, right? Because the cost is driven by the hourly rate we are paying to the agency, and we adjust the rate based on the market every 2 weeks or every month. That's why a 40% reduction in overall agency spend. However, the FTE is like the body, so that's a difference. Am I?
No, again, this is like super good.
Thank
you.
This
is fantastic. If we're paying attention to the numbers, man, this is really doing a bang-up job. This is the kind of stuff we need to present as to the other organization that wants to know this type of information. When they're asking questions and say, how good are you doing? This tells the story. If they can't see this, then they don't understand numbers.
Thank you.
Again, very good. You have to call it what it is. When you do this type of work, you have to acknowledge it because this is what we want. This is how the organization becomes better. So great job.
Thank you so much, the whole team. Thank you so much. Again, this is the top of the priority to really manage the agency based on, all the information cost effectively. Next slide, please. I'll turn it to Charles.
Yep. So being the second to third base, so I just got a couple little slides here that help bring us home. What you see here is our diversity spend in hours for the last quarter of 23, September, November. It's the new one that's been added on since we last presented. But you'd see there, looking at the, going back to the second quarter of the year, we had a slight dip there, but then we rebounded in the third and fourth quarter up to 5.8 and then 6.78. So staying consistent with also with the hours utilized of 17.5 thousand hours of usage there. We always, and so we had a slight growth in the overall percentage, again, of our utilization from the 5.8 to the 6.78. We always, as Dr. Peter said earlier, we do a concentrated effort to utilize 100% of the eligible resources presented to us by our city and county certified MWBs. And you'll see that in my next slide, which shows you the agencies. Well, any question on this before we slide to the next? Okay, so here you see the vendor pool of the 60 plus vendors that she mentioned. Actually, the light blue and the purplish color represents 15 nationally certified MWBE vendors that are part of the overall part of 60. Those in yellow or gold are 5. Those that represent our county and our city certified MWBEs. So those numbers that I spoke of on the prior page are specifically for these 5 vendors' participations. Any questions?
Why is one a county MB versus a national MB?
I'm sorry?
What is the distinction between the county MB and the nationally certified MB?
So the national certified MBE are companies that are situated to provide services to VIA, but their hours worked and the percentage of participation is not recognized by the Cook County Department of Contract Compliance because they're not certified by the city of Chicago or the state of, we have a reciprocal relationship between the county and the city. So only those certified, as we look to, for our aspirational goal, we look to grow participation in Cook County and the city of Chicago. So therefore, those are the only numbers that are recognized as far as the participation and the spend.
Thank you.
All right, you're welcome.
All right, any other questions? Hearing none? Thank you.
Thank you.
All right. I think that's it, right? So with that, thank you, Charles and Bina and everyone else who presented today. Our next meeting again is on March 7th, 2024 at 10 a.m. We've exhausted the agenda, so we're adjourned. Oh, yeah.